you. Thank you for having me. I was asked to present a couple of slides, I think, to showcase a little bit what we do. Maybe not about specific studies, but more where the ecosystem, I think, is hunting for, and maybe where you could contribute in terms of your career stage at a certain point of time. I'm a medical doctor. I studied medicine in Germany, then went to the Netherlands and lots of other countries. And at a certain time doing regular medicine, I thought, okay, but we are too late. I've seen lots of patients with lots of medications. As a geriatrician, at that moment in time, I was managing the hospital. Can we do something differently? And that led to a very long journey of 20 years until I got it a little bit. And that is really introducing the topic evidence-based precision geromedicine. Geromedicine is a new coined term. At the moment, we are talking about healthy longevity medicine. There's lots of criticism with regards to the term healthy longevity medicine because, it's medicine, but what is healthy longevity? It's not Greek, it's not Latin. And that's the reason why we coined geromedicine. So let me know what kind of feelings you have hearing either geromedicine or healthy longevity medicine. And as said, I'm working in Singapore, but also in Amsterdam at the Free University. I have disclosures. Many of these disclosures were already said. Healthy longevity medicine is really dear to my heart. And of course, G Longevity, which is the private clinic. If you're thinking about health longevity medicine clinics, because they're existent, they're growing as mushrooms, I would say, around the world. You first have to define what is a longevity clinic. And if you would ask me, you would get a different answer than somebody else working in the space, because it's really not defined. And Phil Newman, you might know, is a great entrepreneur, but now also really helping the field to not only bring good, I would say, knowledge while transferring articles into educational stuff into, for example, LinkedIn and different media, but he also does the surveys with different people to really understand where the field is. And what he did a couple of months ago, he asked longevity clinics, 51, what their perspective is on longevity clinics and what longevity clinics do. And I can tell you there was so much disagreement what a longevity clinic is, and I will give you an example. Disagreement was with the statement a longevity clinic can only categorize itself as a longevity clinic if it helps its clients to manage their biological age. And hopefully everybody in the room here would say, okay, biological age, we know it's different from chronological age. This is something longevity clinics should do. But not every longevity clinic actually agrees. If you're looking on the right-hand side, the hallmarks of aging, which really define what's going on in our body, how our stem cells work, how other cellular systems work, how our telomeres, how long they are, how much damage we have in our DNA. So what is actually applied in longevity clinics is, for example, measures of chronic inflammation. That's easy to do. I think a CRP can be measured. But very often already epigenetic alterations are being implemented in clinical practice, whereas this is quite in the research field, or telomere attrition, mitochondrial dysfunction, but also think about stem cell exhaustion. I wouldn't even know, me as a researcher and a clinical practitioner, how I can measure stem cell exhaustion. So very often what we are seeing here is that diagnostics is being applied to individuals who are aging, where we do not know if the diagnostics really hit the needle, if we know if they're accurate enough, and if we should apply it. And if you then look at the interventions being offered in longevity clinics, that's on the left-hand side, you see that 71% of the clinics said, I do hormone replacement therapy. That's good, but that's endocrinology. So giving testosterone and estrogens, that's normal care, or it should be normal care. You also see IV nutrient infusions, platelet-rich plasma therapy, it's being topical. So what you see here is that longevity clinics are hugely infiltrated by aesthetic services and by aesthetics. And I always see longevity as something which is curing the inner side of the body. If we can cure wrinkles, that's also okay. We all want to look younger and nicer, etc. But it's more about the beauty and the inner side of the body. So Here we haven't defined really what we are. And then you also see that most of the times these are small clinics, really do not using electronic medical records and lots of paper, etc. So what it really showcases is that yes, we have longevity clinics, it's not defined, and maybe it's focusing on something which is not really based on geroscience and longevity yet. So how to do it differently? We established a group of hospitals working together in Singapore here, Alexandra Hospital, but also Shiva in Israel and the Mayo Clinic in the US. And we said, we want to open longevity clinics and publicly funded hospitals. How do we do that? Who should actually come? And we met 2 years and we defined what longevity actually is and clinics should do, what kind of diagnostics, what kind of outcomes, who should actually work in the longevity clinics. If you will have a career in longevity, you will ask, okay, what kind of courses should I do? Should I become a AI professional, or should I become a physician or a nurse, or all these entities, all these specialisms are actually needed? And then, of course, before you go into outcomes, you need to do something. So you need interventions. And we really defined what evidence-based is. What do we mean with evidence-based health and longevity medicine or geromedicine? And we define that. And I think that's very powerful, because then we can say, without having that huge, immense idea that we have to hunt for patients and money at the moment, that we can say, let's build the structure of evidence. And we said that we want to delay the biological aging of individuals and optimize their health span by evidence-based approaches. So that's published, so have a look. We did that in Singapore too. So we opened last year, seeing 400 participants in 1 year, which will grow if successful. And what we really want to know, if we can improve the biological age of individuals, the cost effectiveness, we want to see, can we implement it? And what is the satisfaction? How can we actually train healthcare professionals? So that's very important. There's one but. The but is that we were so successful that within a day after opening the clinic, we have 2,000 individuals who wanted to come. And it's of course a good problem, but on the other hand side, it brings lots of challenges, because we had only 400 spots. So always, if you do things, do your market research better than we did at that moment in time. So now we're doing lots of studies. How many people would actually come? How many people know about geroscience already who would love to come to clinics? And at the moment here in Singapore, we are knocking on 2,000 doors in Singapore to really include the knowledge while producing our products better. So there's lots to do, and people want it. Here you see the framework, what we do. So we are screening individuals, we do baseline assessments, we are doing development strategy. And then we are really working with clients or with patients for a couple of months before we say, yes, you did it. And we are defining it very well, because if we just would do lots of diagnostics and lots of treatments, we wouldn't actually know when we were hitting the needle and what really would change in terms of a phenotypic characterization based on what intervention. And that's what we have to do. We have to do a little bit of matchmaking between these are the diagnostics and this is what we are doing. And that's what we are defining in the Health Longevity Medicine Society, which I founded 2 years ago, where we really first defined what is health and longevity medicine, or now geromedicine, and that's optimizing health and health span by targeting aging processes across the lifespan. You see the council members on the top, really very dear friends and colleagues, really drive the field. So please reach out to us if you have any questions. Go to the website, become a member. We will change the constitution, hopefully very soon, if our members agree, to also have more youngsters in there. So thinking about having a young HLMS a group where we really make sure that the next generation can take over the work. And it's about optimizing health span, and across aging processes. And I put the alignment of health span in there because here we have a problem, and this is work of Siti, a PhD student of mine from Indonesia, now working in Amsterdam. And I task her with this very difficult question: tell me what health span is. And you might also use the word health span quite often, and you might have different definitions than your neighbor and colleagues. So we did a systematic review to see, okay, what is health span? How often is it being used in research articles? How often is it being published? And what kind of definition do we have? And what definitions are used most frequently? And what we found of nearly 15,000 articles is that we found 187 records defining what health span is, where they say health span is, and what we found is 130 primary definitions. So what is a primary definition? A primary definition, if you define what health span is, but it's absolutely not overlapping with any other definition of health span. That's problematic. A secondary definition is if they're citing a primary definition and then changing it a little bit. And these are 68 more records, so 68 more definitions, which means if you are talking about health span, then I might use very different definitions because we have more than 100 definitions of health span. And if you then say, okay, how do you operationalize health span? So how do you measure health span, which is very important for governments, for example, we found that only 25 out of 113 really defined what health span is. So there's a huge problem in our terminology. So if you want a project or really work with somebody, it can be very easy just defining, for example, first showcasing, okay, we don't know what we are talking about because everybody means something different, and then really trying to build consensus, and that's what City is doing at the moment. If you're looking at which definition is being used at the moment most oftenly, that's the Kabeline from Matt, one paper in 2018. That paper was cited from all the nearly 200 definitions 13 times, and it states that health span is the period of life spent in good health. But it was only cited 4 times without modifications. Also here, it's really, sorry, it's really a mess. So how do we get out of the mess, and how do we make sure that we do good care? And I will just showcase you a couple of frameworks before I stop. On the left-hand side, you have diagnostics, which is very important. On the right-hand side, you have interventions, and they go in circles. So it's like normal medicine, of normal healthcare. You have to, before you treat something, you have to diagnose something. And you see on the left-hand side, biological, clinical, and digital biomarkers of aging. These are our diagnostic tools. And on the right-hand side, you see the therapeutics. And the therapeutics is environmental therapeutics. Think about the noise level at night, that you don't sleep well. Think about the water quality, toxins. Lifestyle is with whom are you married or not? How much physical exercise do you do? Do you have a dog? Supplements are small molecules, and therapeutics are repurposed drugs, for example, but also new drugs. Biomarkers of aging are very important, and you are young in your career. Try always to find, I would say, niches where if you combine your power, you can be very, very attractive of really changing something. You will be very powerful by combining your power. And that's what Madi Carrera and Jesse actually did. They are postdocs in different countries, different laboratories. And they said, okay, we do not know what a biomarker of aging is. Let's bring people together to define it and to work out how we can improve the speed in the biomarker of aging field. So they really brought lots of PIs together and really guiding the biomarker of aging consortium, which was established roughly 2 years ago. On top of it, you see what the definition is. You can read the paper, which is published in Cell, and you also see the definition of biomarkers. I'm not showcasing you to go through all the biomarkers of aging, but I showcase you the power of what you can do if you have a combined question, and how you could guide the more seniors, a little bit with more gray hair, to really drive the field. And that's so powerful. So these are the biomarkers of aging. These are now applied in clinical practice. So if our clinicians here in the room, then you can already do lots of stuff. Don't wait until the latest evidence comes out, because normal medicine already gives you the tools to measure the biological age of individuals. Think about tools which cardiologists use. Think about tools which neuropsychologists use in terms of measuring cognition. All these kind of factors can be applied to aging individuals. And while using the tools, you can actually showcase how different organ systems within an individual age and how they interact with each other. So we don't need so many genomic data or epigenetic data or microbiome data. We can already, at looking at data and looking at trends, because we are I would say, a story in ourselves with genes we have and how we use the genes and what kind of environment and how often we exercise, we are building our story up. And very often in clinical care, we are thinking about snapshots. I'm testing you now, you're okay, you're looking great, come back in a year's time. And then we are not looking back. So always think about in medicine about stories, and we can already do it. So it's a fascinating field where so much involvement is, but based clinical practice on evidence. So that's very important. Very important is also I would say the book your parents gave to you, and that's The Genes. Very recently, a couple of weeks ago, together with Guido Kromer and Carlos Lopez-Otin, we published a paper about the role of gerogenes and suppressors. It's not about that genes are not important, but getting the framework. Okay, we very often forget the genetic makeup we have, and then we do something in clinical practice. How can we now combine that? And there we coined really the terms gerogenes and gerosuppressors. And that's really an analogy of oncology, where we have genes which support to not get cancer and genes who support to have cancer. So we do the same. And then we are linking it to clinical characteristics of the individuals to really then shape precision geromedicine. Also, this one is published, so please have a look. That brings me to my last slide. And that's about really building the ecosystem. We need lots of things, what we also do here in the lab in geroscience, good in vitro experiments, but we also need clinical characteristics, and we need to know what the accuracy is of certain measurements. And while having that and having interventions in hand, we still not can implement it, because aging at the moment, it's debatable if it's disease or not. And if you want to bring it into clinical practice, you need something to treat. So there's the reason why we have to work together with the WHO, the World Health Organization, to really get ICD codes in. So ICD codes are codes in a big book, and these are the International Classification of Diseases. And only if you have a classification of disease being matching with your symptoms, you can treat something, because otherwise you treat nothing because it's not coded. So now a bigger consortia are really working together to see, okay, how could we code aging, what we see, without making all people sick? Because otherwise you are also sick, because we are aging all at this moment in time, and nobody at the moment is escaping. So how do we now realistically bring that into clinical practice with ICD codes? So I would say, very importantly, health longevity is not a hype. It's absolute reality. We can implement it into clinical practice. We need youngsters who really spark up the field and bring some movement into it. We understand it, and we just have to do it in a very smart way. So nearly 20 minutes. That's what my task was. And I will stop sharing and hand over to you again.
Thank you so much, Dr. Maier, for the amazing presentation. Yeah, it's super insightful to hear from you, your perspective of, what has been happening in the space, and how can we contribute as youngsters. So yeah, I guess we can start with a few questions from our side. Maybe Marvin, do you wanna go with your questions?
Yeah. I'll ask a very general one. Nothing to do with longevity clinics, although I have many questions after. But I think it's always good to hear people's start in longevity. And I remember hearing, I think you were on a podcast before talking about that you sort of grew up in a very physician or healthcare focused household. I was wondering though, at what point in your journey that you knew that aging was going to be a key focus within your own career. Yeah, I'm just curious, where was that sort of introduction that, hey, I want to be a physician, also scientist, but also really integrate longevity into it all?
Yeah, it's a very I feel it was a very long journey, but this is absolutely not true, but that's my feeling. Yes, I grew up in a GP clinic, and I was always surrounded with patients. Patients were dying, patients were happy. So I really have very good feelings about growing up in a very rural area, where my father and my mother, both in the healthcare sector, really did everything from deliveries of cows to deliveries of babies to dying people. And I always said, I don't want to do this. So I wanted to study marine biology and study art, and I was quite good, but I think not good enough. And at a certain point, I was convinced, okay, let's do normal medicine. At least you have something safe and you can do research, which is great, because I would say research is nothing else than doing art. If you are not creative, don't go into research. You need to be able to write, but if you can write and you do research, then it's all good and you're creative. And I did lots as a student, lots of research projects, which hugely failed in pulmonology, in oncology. And I was so depressed, and I thought, I will never do research. I will go out of medicine, because everything is dying. Everything is just in my in vitro cultures. It was just not good, because I had no mentor, or of course I had a supervisor, but it was really not going well. So I was at a point to step out of medicine and step out of science. And then I went to China, because out of curiosity, I studied traditional Chinese medicine in Hamburg, in Germany, and I went to China. And then I met this woman, and she asked me, and I know it's very early for some of you, but she asked me to wake up at 4 o'clock to do Tai Chi with her. And I said, Jesus, man, I'm really not a morning person. I'm really not a Tai Chi person, really not. Like, if you want me to do something, don't ask to wake up early and to do Tai Chi. But she was really fascinating, and that was the point. Okay, maybe I give medicine and research a second chance. And I looked. It was at the early times where you had internet, and you had these internet machines making was very early times. I found a mentor in Groningen in the Netherlands. So I moved from China to the Netherlands, and then I said, okay, I will do geriatrics, because health and longevity medicine was not existent. I will do geriatrics and I will do research. And since then, okay, I got there. So it was at the end of my medical studies, but it was very, very frustrating. And from that point, so find a mentor and find something you really love. And sometimes wake up at 4 and do Tai Chi.
No, that's amazing. Yeah. I cannot imagine myself doing that, but I wish I have the conviction, to actually get into such habits. And I have a few questions actually about longevity clinics, if you don't mind me like switching a bit of topic. Because I find them so fascinating as a concept, and I don't think I really heard about them before. I heard some of your talks at ARDD, and then in the talks in Vitaly and so forth. So it just like you got me going thinking about these sort of things. And some questions I have are around why Singapore? Like, did you figure out that there are some specific, challenges or issues with having a clinic in Singapore? Or is there more support actually for a longevity clinic there?
Whatever you do in whatever country, if you think it's easy, it's really not easy, because you are shaking up the entire medical system. And the first hurdle you have to actually take, and speaking to physicians, to say, I'm doing now something which might end up that you don't see patients in 10 years time or 20 years time. So integrated into a medical system is the most challenging, I would say, you can face. Also in Singapore. Singapore has a need, and that is increasing the health span of individuals. So that's the reason why I was recruited to Singapore. I didn't find Singapore. Singapore asked me to come, and I thought this is a great opportunity, because the lifespan is already very high. The universities are very, very good. The healthcare system is good, but the health span is lacking. So, and that brought us to, after lots of negotiations, to not only doing research, but also bring it into clinical practice. Because if we don't have academic centers who are bringing it into clinical practice, we will never actually seeing studies implementing evidence-based or leading to evidence-based care, because otherwise it's only driven by private clinics, and they don't want, or they are not going to do big implementation sciences. If you really want to change healthcare, you have to have sociologists, psychologists, and team. What do people see? What do people think? How do you implement it? How do you change? Who's going to pay? Economists are very important. And Singapore really sees this as a niche, as some other countries now too, and that's the reason why I'm here.
I guess just adding on to Denise's question, because for us, like Denise said, this idea of health longevity clinics is very new for us. I think even the first one was probably somewhere in California, maybe 10 years ago, or a little bit more than that. I'm curious, having been in this space for a while now, have you seen the idea of these longevity medicine clinics evolve in some way? Has it been easier to establish them? Has sort of the way they're able to operate changed in the last 10 years? And also, I'm curious if you could speak on sort of what NUHS is doing and what sort of the Chi longevity, if you guys are doing something different than what maybe we thought what a longevity clinic was really 10 years ago.
Yeah. So yeah, it's getting easier, but because the driver is that there is a market. So people now understand if they're aging that, hey, you could do something. So, and especially the ones with means, financial means, they are now going to longevity clinics. That's the reason why it's growing as mushrooms. It's because it's the right climate. It doesn't mean that there's more evidence compared to 10 years ago. There's absolutely more evidence in terms of diagnostics, biomarkers of aging, and there are more interventions, especially from a lifestyle perspective, because there's lots of research. So it's not easy, but it's getting easier. And we have now 3 hospitals and publicly funded hospitals who are now establishing the clinics. For the ones who do not know what really a clinic is, so in most of the clinics, everybody is welcome who is an adult. So most of the longevity clinics do not treat children because this is development and we do not know what really aging is in development and how to disentangle. And also if you are looking at biomarkers of aging, who should estimate your biological age, we don't have the cohorts, for example, to really estimate that. So adults without chronic diseases are all welcome because everybody is aging. What we really try to understand is how the genetic makeup is interacting with the clinical phenotype. What is the heart function, lung function, cognitive function? How is the environment? How is somebody dealing with aging? How is somebody dealing with the deteriorating body? Or the outer side can tell you once you pass 35 or 40, you're really looking different compared to when you were 20 or 25. So with every, I would say, 5 years, look at your photos, you really see it. And people there was worry, and they want solutions. In terms of what we do at NUHS, so that's the university side, we do observational studies, but also aiming to do a randomized controlled trial with the idea to showcase the effectiveness of longevity clinics. Think about people go to the GP, people screen or get screenings and then go home again. How would it be if we are not only screening for example, diabetes or hypertension, if we could also do a longevity clinic next to it and really accelerate the knowledge while seeing what is evidence-based? And so we're now aiming to do a randomized controlled trial. We are including the normal population who is coming to GPs and say, would you be interested to be upgraded? Think about an upgrade in a plane, upgraded into a longevity clinic. So we will have 2 arms and then actually see, do the individuals in the longevity clinic plus the normal GP care, are they better in terms of the aging profile a couple of months, years later compared to the ones who were just GP trained? And I think this is the only way to really showcase if longevity clinics have an additional value, because otherwise we are recruiting always the best of the best, the very well, and the ones with lots of finances, which we see in very often in private practice. So that clinic runs at NUHS, and then I have Chi Longevity. Chi Longevity is the evidence-based clinic tech-enabled in the private sector, which is doing very well. I think we market ourselves very well because we really only want to produce good care being evidence-based. So we are quite separated from other longevity clinics who very often do stem cell therapies or exosome treatments or whatever treatments and injections where there's no evidence. So we are really sticking to that evidence-based rule, which is very deep in my heart as publicly a trained physician and as clinician scientist, that we really provide very, very good care now also in the private sector.
And something I often think about is what you mentioned also in your talk about the recognition given by regulatory bodies and the fact that longevity clinics are, as far as I understand, are not yet recognized. Is there anything that should happen down the line in order to get longevity clinics accredited, or is there even a need for them to get accredited?
Yeah, very good question, and a question which we are tackling at this moment in time. How can we make sure that there are guidelines and we can get longevity clinics accredited? So what we are doing now is working on the criteria. So what should a longevity clinic do? What is a longevity clinic? What is the basis a longevity should do in terms of diagnostics and interventions? So very important is to work together with governments because they have to implement it. In the end, you can implement it as a society, but then it's more like a certification, which might not be so meaningful. So we really want to bring it from a certification from the Health Longevity Medicine Society, but then working with the governments who are regulating actually clinical care, that they also regulate this space.
I promise I have like one more question because I realize there's so many questions coming in. I don't want to take up all the time. But the last question I have for maybe Denise, you want to wrap it up, was about the trial you're talking about with was it 400 people for the first year, which expands probably to thousands in the future. I was just curious about, like, thinking about it, like you have hundreds of markers and then hundreds of interventions and then hundreds of outcomes to look at. It just seems to be so much. So I'm curious about, one, how you really decide what's the most important, both from the clinician side and also what's actually going to be actionable for the patient. Because I'm assuming that you have some outcomes or things they need to do, but it's not like they could remember, hey, take 100 medications and remember to track all your gait speeds and your your life-based mobility. So how do you make these actionable steps for patients to actually integrate into their lives?
Yeah. Okay, two questions. What is the primary outcome? How can you actually say that it's effective? And secondly, how do you motivate individuals and what do you ask them? The first question is, we defined a primary outcome, which is based on conventional care, where we actually know if it could be, if the change is there, effective and especially cost effective. And we defined it as change in CRP levels, so an inflammatory marker, a HbA1c for glucose control, and a lipid marker. So we defined how much reduction of improvement of these markers we would like to see in clients who are coming, which are defined based on clinically meaningful changes. So that's absolutely defined because otherwise you cannot do a randomized control trial. What do you ask patients to do? First of all, you have to prioritize. You have to prioritize and decentralize. Prioritization is very important. If you're just saying, okay, your biological age is 3 years older and like everything is not going well, nobody will be motivated. So you have to tell people what can you actually do. And you have to ask people what they want to change first. Is it more sleep patterns, physical activity, taking a pill, or working on physical activity next to getting a statin or metformin if it's a pre-diabetic? So it's really about what the goal is of somebody and where the biggest, I would say, fish is to capture. Because we already know that if you're looking at your body, the organs age quite differently and different pace, but also different mechanisms might be involved. So you really have to tackle it well, that you are not ending up to just selling WHO guidelines, because that's not very attractive, because everybody knows that we should move more and eat better and sleep better and have no stress and whatever it is. So you really have to now tailor it. And that's the reason why I'm so excited about the genetic component. Also now we are bringing it into the field. And decentralized, I mean digital biomarkers. So we are tracking individuals while they are having a ring, a smart ring or a smart watch, and then it getting easier. And then you can nudge individuals at certain time points where you see, and very often healthcare coaches are doing that, where you need that nudge. I would
great.
need a nudge now because we had just a deadline and I really have to move to get my physical activity up since a couple of days. So I would now see, okay, my healthcare coach, give me a nudge. Okay, I know I will do it. And I wouldn't do it because I'm tired. And now I'm doing it because somebody is watching me.
Okay, amazing. We're gonna open up the floor to some participant questions. To start, we'll do one chat question and then we have one raised hand question. I know Khalid, I noticed you raised your hand earlier. So to start off, Jessica asked, what is the story behind the founding of HLMS? What is HLMS focusing on right now?
The founding idea was frustration. It was continuous years of frustration that nothing is really happening on the clinical field. And then some others also had frustration, and that's where the council members. And then we said, we are so frustrated, let's do it. And let's found another society. So that's the reason. What we do is really bringing a network of healthcare professionals together. That's first. The second is building guidelines, saying what's evidence or not evidence, and regulations, and to really watch the field but enabling the field, and that's most important.
Yeah, that makes a lot of sense. Yeah. Khalid, do you want to ask your question?
Thank you. Thank you, Professor Andrea, for your lecture. My question is, I'm curious to know, as a medical student myself, and I hear from your story you're a physician, how did you deal with the friction from the medical society? So I know it's still there, but since you're one of the early people to introduce longevity and preventive medicine, how did you deal with it? As we know, the current medical mindset is do not treat healthy people. Everything you do must be proven by a guideline, by a randomized controlled trial. So do you stick only to lifestyle interventions which are harmless, or do you do other things? Thank you.
Yeah, so a couple of questions in here. So how do I deal with colleagues who do not understand the field? I think talking to them, I did give lots of lectures. Some then understand. And I think if you're talking, physicians are smart, but physicians, and I managed hospitals, it's very hard to change their habits. But they understand, because if you're putting, and it's the most powerful slide, but I don't like it really. If I put a photo, me in my 20s and me now in the 40s, and it's so obvious. And then they say, okay, they're healthy. No, it's not healthy. Like, look, okay, is there change? Yes. Okay. What is the change? Rimples. Okay. Why are there? Because of fibroblast. Okay. Okay. Okay, so we're getting there. The skin is changing. What else happens in the skin? Oh, senescent cells are occurring. Okay, senescent cells. How are senescent cells associated with cancer? So we're getting there. Just showcasing, we're asking them, do the same. Look in the mirror. What do you see? Do you see something? And then you can have the discussion about what is health. And I think we haven't really tackled that in the entire field, and there are lots of debates in our aging field. What is health and what is aging? Like, stop with it. Like, let's define it, stick with it, and make it better in the next coming years. I think everybody now well understands that aging is nothing else than a state towards diseases, which we have defined well. So now we have to define the stages of aging well, and tackle them as a sort of disease. So I have nothing against calling aging stages a disease, or let's call it a staging system. And then also healthcare professionals understand how they deal with it. I think we have to just operationalize it, and we haven't done it yet. And the second question was, okay, are you only doing lifestyle, which is not sexy, it seems. But I think it's most important to actually see, how do you do it well? How much resistance exercise training do you do? How much do you need? How much endurance? How much balance? How much broccoli because of what do you need to eat? How much cucumbers? And to really shape the microbiome well. No pill can do that, even not probiotics. No, I do not do anything which is not evidence-based, but we are creating the evidence. We are creating the evidence doing many randomized controlled trials with small molecules, with repurposed drugs. But in the end, I think we have to make sure that our field is safe in implementation, because I do not want to blow up the field. And honestly, if I don't have the evidence, I don't want to prescribe this as a physician, because I want to know that it works. But everybody in the field is, I think, responsible to also start now with case reports. Nothing wrong with case reports actually showcasing, okay, there's a biohacker, what actually happens and why might that happen? The entire, I would say, medical field grew up because of case reports. And then we went into evidence-based medicine while having Cochrane, etc.
Thank you so much, Dr. Maier, for your response. Yeah, and I'm going to continue with the questions in chat because I don't want to go too much over time. And we have a question.
Julian, do you want to ask your question next then?
Yeah, of course. Yeah. First off, thank you, Professor Andrea, for your time here. And my question is, so it really seems like biology as an engineering field is really opening up and becoming a new possibility. And there's so many different majors out there, like bioengineering, chemical engineering, bioinformatics. There's just so many different ones out there that can help find the answers of how to reverse aging and stop it, ideally. And recently, the CEO of NVIDIA said that biology has the opportunity to be engineering and not just science. And so with that said, what type of bachelor's degrees and master's degrees would you say deal with finding out how to engineer cells to live longer and potentially forever?
It depends on where your love lies. So follow your heart, what you really like, because we need sociologists, how many people, who should you stick together, green space, environment, if you like architecture, just go for it. I think there are so many niches we haven't discovered. I think we are really overrating just the biology, because the biology is interfered with the environment and with our needs and with our thoughts. I think at the certain time we are also engineering our thoughts and our feelings in the end. But I think we need at the moment individuals from all areas working together. And I just would follow your heart, because everything is about longevity in the end. It's about environment. It's about avoiding toxins. It's about there was chemistry. It's do whatever you think you really love and you're good at. So don't just do something you love and you're not good at. I think find the best match. Yeah.
Okay, thank you.
It's, by the way, very good. Ask somebody else also, where do you think what I'm really good at? Yeah.
That's
Thank
really
you.
good advice. Next, we have a question from Yo, if you want to ask.
Hi, thanks, Prof. Andrea, for speaking today. So recently I heard of a contract research organization, CROs. So my question is, could you share your thoughts about how meaningfully can someone contribute to longevity science by working in a CRO?
Well, very important. CROs are dominating the field in many specialities. Without the CRO, we wouldn't have all the drugs already being on the market in conventional systems. So I think now we are getting attraction of bigger pharma, and then we can pay CROs to do the studies. So for the ones who do not really know what CROs are, so you can do research and you can either do it yourself or you can outsource it. So these are the outsource studies, which are great, because if you have multi-center trials, think about 200 sites where you're recruiting individuals. You need contractor, you need to do it right. So they're absolutely there, and they're just touching now the longevity field. We are working with a big player in software to decentralize trials. that people can have an app where they know what medicine to take and what the next regime is, etc. And I think that's the next step. So we have to scale up to be successful because many of our trials are too small at the moment.
Thank you.
Great. Thanks everybody for the contributions. Is there any questions that anybody wants to ask to Professor Maier? Feel free to raise your hands or just unmute yourselves and yeah, ask any questions.
Who has heard about the longevity talent incubator? Talent incubator of the NUS Academy for Health Longevity. Jessica, you shouldn't speak up now. You know it. And David? I see a couple who already were in the talent incubator. Anybody knows about the talent incubator? No? We just found it because education is quite poor in our space. We founded the NUS Academy for Health Longevity. And within the academy, a highly subsidized sort of boot camp is being organized every summer. So we just had our last boot camp, and Jessica, you was part of it, and David Maier was in the first round, where we really bring youngsters together, highly selected, and then we boot camp with them with us as staff for 11 days on the university. It's quite intense and really, yeah, brings people together to form a network, as you already have the network, which is super great to see. What drives you in the field, if nobody has a question for me? Not happening very often, by the way.
I guess I can go. So I think initially what drove me in the field was the impossibility that seemed to be attached to the question of, can we solve the problem of aging? Can we extend health span and lifespan to the extent that we are able to do right now? And eventually became a bit of a personal quest too, in terms of, oh, this actually affects me too and affects everybody around me. And yeah, I think I took it from scientific curiosity to the space of, wow, this is a problem everybody's going through. This is not just my little side quest that I'm doing. So yeah, I think this is why longevity for me.
Yeah. For the ones who are a little bit already in the field, what would you give a little bit of feedback to people like me? What should we do differently? It's a very open question, I know. You can interpret it in very, very many ways.
I have an idea, so
Oh, sorry.
I'll
Go ahead.
okay. Okay. Oh no, you're good, you're good. Yeah, so my idea is try to market the benefits of longevity to the average person and try to speak their language. So I think the average person, they probably, at least in the US, I imagine that they probably care about saving money and I don't know, maybe spending more time with their family, being more energized. So maybe you can be like, if you reverse your aging and if you focus on longevity, then you'll be more productive at work. You'll have a higher output. You'll get a higher salary as a result of that because your mental output is going to be a lot more optimized because you're actually feeding your body good stuff and it's perfectly tailored for your DNA. And even though it might be kind of expensive to go to the longevity clinic, you're going to have all these amazing side effects as a result. So you should go to a longevity clinic. So that's kind of my idea.
Great. Anybody else?
So I think perhaps this is already being done. I'm not really sure, but I think twin studies would be a great way to, kind of like figure out the genomic and epigenomic differences between longevity markers and hallmarks. So perhaps like a large scale twin study around the world would help us pinpoint where some of the, well, environmental factors and gene environment interactions that could potentially accelerate or decelerate longevity.
Yeah, there are a couple of consortia who are doing that, but I think it's really underrated. Yes, there are more twins than twin studies.
I think I would second the idea of more basic research. I left research for the very reason that I feel like I'm too clumsy and I'm too impatient to do it. But I definitely support it. We need a lot more and to go beyond what we call at the moment the hallmarks of aging and yeah, figure out correlations between them.
Yep.
Hello, Professor Andrea. I do have a question for you. So what do you think the scope of telemedicine is in increasing health span through these longevity clinics?
Telemedicine, you say?
Yes.
Yeah, huge. I do this very often. So the majority of patients we as of clients we are seeing with telemedicine. So it's very important because we learned during COVID that telemedicine is absolutely something good. It's acceptable. You're giving a good quality of care at some stages. And if you have a good relationship with the patient, do telehealth, absolutely. So it's really an enabler, but it's just a tool. So I think first you need to do what you do. We have lots of, I would say, diagnostics, which you can already do at home. We have interventions, which we can do at home. So why shouldn't we communicate via tele and then do medicine?
Okay, I guess, sorry, I know we're coming up on the hour, so if there's no more questions, I guess we can just wrap up for today. I guess I know other than the talent incubator, I think everyone should do it. Obviously, we have some bias here. I know Jessica will pitch it to us, of course, and of course you, Professor Maier. But just any last words of advice for young people, like, do you have any recommendations for us in terms of getting involved in the clinical side of longevity? I think there's a lot of advice for the scientific side, and if you want to be a physician, of course, but how can we get involved in this aspect of longevity?
I think the longevity field is very open. So first of all, find a mentor to guide you, because just here you have all different needs. So really find a mentor in the longevity field you talk to frequently. The field is changing, giving you directions, helping you to find a good group to do research or clinical practice or whatever. So don't do what I did when I was in medical school. I just did something and it failed massively, or it had not much input of impact doing research. So find really somebody who has time for you to talk sometimes. Doesn't mean that you have to meet every week, but at least when there's something coming up, you can send a message and help you to find your way in this growing field. If it's scientific, so preclinical or clinical, whatever, follow your heart and just do it. Like I would love to be student again, or like follow your heart and do it and go for it. And you will never have so much freedom in your life. Just go and see the world and see different research centers, see different countries, habits, just learn. That's what I did well. I really traveled a lot, but really enjoy it. Yeah.
Yeah, awesome. Thank you. And I guess if people are looking for a mentor in yourself, how can they actually reach you after the call like this?
Just add me or send me an email. I can do it I can send my email in the chat. It's very easy to find, by the way. So if somebody is not finding my email, then there might be a problem. Here it's
Okay, awesome. Thank you so much then. I guess, yeah, that's a wrap for today, guys. Thank you all so much for coming. I know it's really hard to coordinate time zones across North America, Europe, Asia. So I know it's like 2 a.m. for some of you guys and like 5 a.m. for others. But yeah, thank you so much for coming. Thank you, Dr. Maier, for coming today.
Bye-bye. Have a great career, please. Bye.
Bye-bye.
And fun in life. Bye.